Hello everyone. This is Dr. Ameya Kulkarni, joint replacement and arthroscopy surgeon at Sanjeevan Hospital, Nashik. Today we'll be discussing about ACL avulsion injuries, everything from the causes, symptoms and surgical considerations. So what is exactly a ACL avulsion injury? A ACL avulsion injury is when the ACL ligament is avulsed off the bone along with a small fragment. It usually occurs on the tibial attachment of the ACL and is more common in children and younger adults. So like you can see on the left hand of your screen is an X-ray of a ACL avulsion injury where you can see a small ACL avulsion fragment. And on the right of your screen you can see a MRI picture of a ACL avulsion fragment with the ACL intact. ACL avulsion fracture has four basic types. Type 1 is the undisplaced fracture. Type 2 is minimally displaced fracture with a posterior intact hinge. Type 3A is the completely displaced fracture not involving the articular surface, whereas type 3B is completely displaced but involving the articular surface. Type 4 is the comminuted type. ACL avulsion injuries usually present as a painful and swollen knee. They have a history of twisting injuries and can have instability or buckling while walking. So, what are the treatment considerations for a ACL avulsion injury? Type 1 and type 2 reducible ACL avulsion injuries can be treated conservatively, whereas type 2 non reducible and type 3 and 4 need surgical management. So, let's talk about conservative management first. Conservative management involves a above knee cast in extension for 4 to 6 weeks. Check x-rays are taken every week to confirm reduction. Conservative management can cause a lot of knee stiffness and requires physiotherapy after cast removal to regain full range of motion. So surgical management is basically divided in two types of treatment modalities. The old and the traditional way is open reduction and internal fixation. This is good for large single avulsed fragments. Internal fixation devices like CC screws or headless screws can be used, but they cannot be used in skeletally immature patients as they can damage the fascial plate. The recently more common technique used is the arthroscopic pull-through technique. This technique is minimally invasive, hence it has a faster recovery and does not cause any damage to the fascial growth plate of the patient. So let's discuss this case. This was a 16-year-old male who came to me with a twisting injury and had significant hemarthrosis. He had knee range from 0 to 120 degree and was painful throughout the range. You can see his x-ray on the right hand of your screen with the ACL avulsion fragment. This is his MRI showing a ACL avulsion fragment with an intact ACL and some bony contusion over the tibial surface. On the left of your screen, you can see an arthroscopic picture of the ACL avulsed fragment, whereas on the right of your screen, you can see the X-ray. So in this case, I had passed two fiber wires around the base of the ACL and cinched those fiber wires around them. And then, as you can see on the X-rays, I passed two bit pins from the anteromedial surface of the tibia through the crater of the ACL avulsion and through the fragment. And then I pulled the fiber wires through those bit pins and tied them on the tibia over a bone bridge. This is the clinical picture through arthroscope after reduction and tying the fiber wires on the tibia. And this is the post-op X-ray of this patient showing good reduction in AP and lateral views. So for this patient, I started his physiotherapy right from day 1 of surgery, where he started closed chain exercises from 0 to 60 degrees and full weight bearing mobilization, as this fragment did not involve the articular surface. Over the next 3 to 6 weeks, we will progress to full range of motion and full weight bearing without a brace, and hoping for the best outcomes. Thank you so much.